Hello, good evening everyone. This is Dr. Nikhil Parwate, consultant gynec oncosurgeon at Aditya Birla Memorial Hospital, Chinchwad, Pune. It's great. I take this opportunity to share few thoughts related to ovarian cancer through this video. Whenever we talk about women, everything is set around uterus. But ovaries are the major reproductive organ in a woman's body. It is ovaries that make a woman a woman. So these are two small, around 2 to 3 centimeter tissues which are very adjacent to the uterus. And ovarian cancers are basically two different types of cancers presenting at two different ages. So one, we have something called as epithelial ovarian cancer, which generally presents in women who are above 40 years, and germ cell ovarian cancers or tumors, which are present in younger generation, generally after 10 years of life. So 10 years, 20 years, and early 30 years, majority of the women have germ cell ovarian cancers. Above 40 and above 50, most of the women have epithelial ovarian cancers. The understanding of these two different cancers are completely different. Management is completely different. Ovarian cancers, very technically speaking, can affect any woman. Why? Because every month a woman ovulates, and because she ovulates, hence 15 days, around 14 to 15 days post ovulation, she menstruates. Now, the liberation of an egg from the ovary involves breach in the lining epithelium of the ovary. So once the egg is liberated from the ovary, it has to breach the epithelial lining and then come out of the ovary, which means the ovary itself has to repair every month that breach that occurs in that epithelium. So imagine that something is being breached repeatedly again and again every month, and again getting repaired every month. So this entire process of ovulation, according to me, itself is prone to invite cancer in any women, which also means that in spite of this event happening throughout the reproductive career of a woman's life, still they do not suffer cancer of the ovaries. So that's the beauty of it, and that is why when we talk of epithelial ovarian cancers which occur after 40, most of the cause of these epithelial ovarian cancers is because of this process of repeated epithelial breach. But when we talk of ovarian cancers in younger patients, 10 years, 20 years, 30 years, it is most of the times inherited. Okay, or most of the time these girls already had some expression of the cancers when they were in their mother's womb, and that is why they are called as germ cell cancers. Unfortunately, I mean, there's a lot of scientific evidence, a lot of guidelines, a lot of information that are coming in as far as ovarian cancers are concerned, but unfortunately there is no method, a specific method used anywhere in the world to prevent an ovarian cancer. Just like cancer cervix can be prevented by frequent screening with a pap smear or an HPV test, similarly, we have nothing for ovarian cancer which we can guide a woman that you need to do these tests at this particular interval starting from this age to prevent an ovarian cancer. So as far as prevention of ovarian, many things are put forth, something like a transvaginal ultrasonography in a woman above 45 years, CA125 blood tumor marker test at the age of 50. But please understand, these are not preventive methods. So as far as prevention is concerned, there is nothing on offer as of now to a particular woman to prevent them from an ovarian cancer, because as I said, these cancers present at two different ages in two completely different methods, and none of the methods can be prevented. So prevention is not there in ovarian cancer. And look, if you look at the history of how ovarian cancer develops, it is correct that it is very difficult to prevent because we cannot predict it only. We have hardly anything to predict it. So once you cannot predict, it is very difficult to then think of prevention also. That's the reason we do not have prevention in ovarian cancer. Detection, well, very frankly speaking, ovarian cancers, of course, they never come to gynaecologist. They even hardly go to gynecologist. Why? Because detection, because symptomatically, the symptoms are so varied, right from pain in abdomen, lump in abdomen, mass in abdomen, vomiting, belching, retching, breathlessness, chest pain, constipation, diarrhea. All these symptoms not cause of a problem. These patients, in fact, I would say majority of them are never seen by even a basic gynecologist. So it's most of the family physician, the general physician, the chest TB, the gastroenterologist, the general surgeons who see these patients. Why? Because as I enumerated, the symptoms do not point to a gynec cause of this particular disease. And of course, they have no relation to your periods also. Ovarian cancers do not cause any major menstrual upset. So definitely a gynecologist is generally not involved. So once when they go to these people, they first try to treat this patient symptomatically, and when the symptoms do not relieve, then a basic investigation is being planned. And the basic investigation which picks up this is a ultrasonography of the abdomen and pelvis. A simple abdominal and pelvic ultrasound is good enough to catch these tumors. And from there on, the process of identifying the ovarian mass then comes up. So what the ultrasound really picks up is abdominal mass, which is probably originating from ovary, and then whether it is cancerous or it is not cancerous. So then you have your blood tumor marker test like CA125, CEA, CA199 for epithelial ovarian cancers, and alpha fetoproteins LDH, that is lactate dehydrogenase, and beta HCG for germ cell tumors. So next comes in these blood tumor markers, which probably gives you a faint suspicion for a possibility of a cancer. And then comes the further tests like CT and MR to find out what is really happening with that mass and tumors. So this is how the detection goes. So the patient may be coming with a lot of belching, retching, vomiting. She goes to a family physician. He gives her some medicine. She does not get relieved. Then the pain increases. Then she's referred to either a gastroenterologist or a general surgeon. Then they see her, they evaluate her, then they investigate her on the basic investigation being a sonography. So once a sonography test has been done, then probably they find out that there is some mass in the abdomen, which is probably arising from the ovary, and then the treatment plan or the management plan shift towards an ovarian mass. Then these tumor marker tests are advised, and once the tumor marker tests are elevated, then probably a CT and MR scans are advised, and that is how a complete diagnosis of the ovarian tumors or ovarian cancers are being made. Mind you, not all ovarian cysts or ovarian masses are cancerous. They are non-cancerous also, and in between the cancer and the non-cancer, you have something called as a borderline ovarian tumors. So you may have after all these investigations, you may have a ovarian tumor which is probably not cancerous, probably cancerous, and something which is borderline. So this is where a gynec oncologist comes who helps you to distinguish between this and then formulate correct treatment management based on what is the best possible diagnosis and what could be the best possible remedy. Whenever you talk of cancers, you always obviously stage them as stage 1, 2, 3, 4. Similarly, for ovarian cancers also, we have the FIGO, that is Federation International Gynec Obstetrics. We have the FIGO staging for ovarian cancers, and based on the stage, we treat these patients. As far as the epithelial ovarian cancers are concerned, which is generally seen in women post 45, post 50, the early stage cancers, the stage 1, 2 and maybe very early 3 definitely can be treated by first surgery and later on by chemotherapy. Advanced cancers generally require a chemotherapy first and then a surgery. Radiation has no role in ovarian cancer. So ovarian cancers are primarily managed by surgery chemo or chemo surgery chemo. So that is how a majority of the ovarian cancers, that is the epithelial ovarian cancers, are managed. Most of these epithelial ovarian cancers, since they are seen in women above 50 years, hence there is no need to ask the reproductive needs for a patient, as most of them have the families complete. As against this, germ cell ovarian cancers, which are generally seen in younger girls, say 10 years, 20 years, 30 years, the management lines are completely different, because here if a 12-year-old or a 14-year-old girl comes with a germ cell ovarian cancer, the next thought is how should we save the future reproductive and fertility life of these patients. So in most of these cases, we definitely do something which is called as fertility sparing surgery. And in this, we only remove the ovary and the fallopian tube and keep the rest of the things inside, and probably we remove few other pelvic lymph nodes and omentum. Many times we find that if advanced stage of a cancer, still in those patients also we keep the uterus and the other ovary. After removing one tube, one ovary, nodes and omentum, we give them chemotherapy. Now most of the chemotherapies which is being designed and formulated for germ cell tumors, after taking those chemotherapies, majority of these girls, they get their menses back, say within 4 to 5 years of completing the chemotherapy, which also means that ovulation and menstruation begins. So many a times, either in these patients, we take the eggs and freeze them before initiating the treatment, so that they remain there. And in most of these patients, of course, this requires a lot of counseling before initiating the treatment, because if at all there is treatment failure, then all these girls will have to undergo complete surgery wherein they'll never have uterus, never have ovaries, anything, and it will be completely shut down of their reproductive and fertility career. So all these decisions are really based after a lot of counseling and lot of understanding, and again the giving that option of egg freezing. So that is why in young girls, treating young ovarian cancers is always a dilemma. There should be a lot of thought. It should be a multidisciplinary approach where you many times we involve even the IVF persons also, if they're able to freeze out those eggs prior to treatment. And many times if only a surgery is done, then even after surgery, even after starting a chemo, you can freeze the egg. So all these things need to be spoken to the patients and then managed. Again, as I said, even for germ cell ovarian tumors, there is no role of radiation. It's mostly the surgery and the chemotherapy. The surgery, as I said, is fertility sparing surgery, which enables that particular young girl to meet her future reproductive needs, and most of the treatment is planned accordingly, and it is most of the times a multidisciplinary approach. So talking of ovarian cancers in elder groups, I mean, I've rarely seen early stage 1 or maybe stage 2 ovarian cancers. Most of them come in advanced stages only, because as I said, it is very difficult to pick them up, and by the time they're picked up, it's always a lot of time lost, because just pain in abdomen or just a bloating in the abdomen gets revolved around too many specialties till a clear conclusion that this being an ovarian mass or coming from an ovarian cancer comes. Second, what I will say in fact in this is that any women above 40 or 45 years, and especially those in menopausal age group, who have been diagnosed to have an ovarian cyst which is about above 5 to 7 centimeters, needs to be investigated keeping cancer in mind. So the idea is you rule out that there is a cancer or rule in there is a cancer. So any 5 to 7 centimeter cyst in a woman above 45 age should definitely be critically evaluated for cancer. So it is important to disprove cancer in these patients. Similarly, as far as the younger age group is concerned, you need to keep that threshold of around 7 to 8 centimeters. Of course, most of them are definitely benign in younger age group, but still that thought that yes, could this be a cancer should always come to a clinician's mind while you're evaluating a cyst which is greater than 7 centimeters in these girls. So this is the crux of managing ovarian cancers.